Welcome to Medheads, the weekly show that brings a biopsychosocial focus to issues of the day, along with special guests who will showcase their expertise and enthusiasm about their field of practice. Your host, Dr. Fergal Armstrong.
Hello everyone, my name's Dr. Fergal Armstrong and welcome to this episode of Medheads. And today we're chatting with Andrew Rees. Hello Andrew.
Hello there, Fergal.
So I thought we'd talk a little bit more today about human needs as constructed by Max Neef. And in a previous episode you gave me a case vignette, so I'm going to give you a case vignette first. So I have a case of a gentleman who's gay. He's in a same-sex relationship, a de facto relationship. And he was admitted to a district general hospital with acute liver failure and a hepatic encephalopathy. And this was attributed to long-standing alcohol use disorder. And he was discharged and told to basically get help for his alcohol use disorder. And ultimately he's ended up under my care. And it transpires that he denies, since his discharge, he denies any use of alcohol, but acknowledges that he needs to stay on his benzodiazepines that were initially prescribed to him by his psychiatrist a number of years ago, and that he's continued till today to use and to need. So he needs at least 10 milligrams of diazepam a day. Whilst he was in hospital and near death, his de facto partner managed to, by some mechanism, take control of this patient's bank accounts. And the patient has come out of hospital having survived a near fatal complication, to find that he's not in control of his bank accounts, he's not in control of the farmland that he runs, and he's also got, he lives on acreage, he's got, he keeps horses, he's an ex-model, and now his parents and his de facto relationship partner are fighting over control over his bank accounts. He then also has told me that, or alludes to the fact that he feels that he's being abused by his de facto partner, who is potentially stealing his medication, in particular his painkillers that he's using for his chronic back pain and his benzodiazepines. One of the local pharmacists has also suggested that he is worried about the fact that the patient may be misusing horse tranquilizers because the patient's appearing drug affected and presenting to the pharmacy with multiple prescriptions for veterinary medicines, which are allegedly needed for his horses. So that's the case that I've been managing or dealing with recently, and I was wondering how you would analyse that through your interpretive lens.
Well, certainly there are a number of human needs that don't seem to be met there, and I think that the end result of that would be phenomena such as chronic anxiety, and from that you're very likely to get depressive illness as well. So this poor man is really, I suspect, struggling with a lot of things. The kinds of issues in this, sustenance seems to be threatened. The thought that might not be able to get a meal, shelter, protection, not being able to get into one's own home, that would be very difficult. Just the underlying illness is going to make it potentially difficult for this chap to engage in anything purposeful. It's not impossible, of course, but it would make it more difficult. I'm not so sure at the moment that the aspect of understanding or wisdom comes into this, but it may fall out as we go through things. Nor creativity, I suspect. This man's position in life, again, was once a model, had a certain status, one would think, and probably felt they were quite well thought of in their chosen craft, and that's perhaps gone by the by. Oh, well, affection. It doesn't sound like there's a good deal of affection between them and their partner. Perhaps their parents' motivation is more aimed to their welfare, but we don't know the details of that yet. And I'm just, I think we've pretty well covered everything. The other last one I think is Transcendence, which is perhaps part of identity, legacy, the idea that one might hand something on to coming generations. I'm not sure that that fits at the moment, but again, that might come to the fore as we discuss the case. So they would be some thoughts to start with.
For me, this patient has had a significant identity crisis. He nearly died. He was admitted to the intensive care unit in organ failure. That must have an incredible effect upon people's outlook in life. The fact is a near mortal illness. How do you reckon that changes you in terms of how you look upon life?
Well, it can. I think it can swing either way, can't it? Some people use it as a springing off point. They realise that life is short and that they ought to perhaps be committing themselves to greater things. For other people, they're just struck by the fear of their own demise. They recognise that life is so short and they might withdraw into themselves. So there's any number of responses.
And then, of course, we see people who go through near fatal or illnesses or significant illnesses who also suffer from comorbid substance use. And others are surprised that despite having engaged or suffered from a near fatal illness, they haven't changed their ways. Yet it's important to acknowledge that continued use of a substance, despite harms, is actually one of the diagnostic criteria for substance use disorder. So for me, on the one hand, this patient, he has, at least he says that he stopped drinking, but he continues to be dependent on benzodiazepines and he continues to be possibly misusing opioids, although to a lesser degree. So he's absolutely unwilling to acknowledge the possibility of him having a dependency. He feels that he needs to use his benzodiazepines to manage his ongoing anxiety, which is as a result of his current psychosocial stressors. So I've told him that, in my opinion, benzodiazepines beyond 4 weeks are really only treating an ongoing benzodiazepine dependency. They're not treating an underlying illness. But he's reverted back to saying things like, oh, well, this is prescribed by my psychiatrist, therefore you cannot touch it, or, my psychiatrist is going to disagree with you, and, I'm going to see my psychiatrist and he's going to sort things out. How does that fit in with this lens of human need?
Well, I think meeting fundamental human needs is an important starting point. Often I use it as a means of distilling what is it that's irritating the soul. What is it that's needling this person? What thing is unmet in their life? I suppose in many ways it's sort of an idea of treating a kind of chronic pain, whether it's physical pain or emotional pain. Looking at what kind of experience is this person feeling a need to avoid, not being prepared to confront certain discomforts and dealing with those in a rational way. So looking at the human needs is not an end in itself. It's a starting point. It opens the door to discussions. Sometimes people say, I don't know what's going on. I don't know why I've got this problem. And then when it comes to the substances, often it's self-medication. The person has these needs that are not being met. They have this pain, however it presents itself, and they're seeking release. And so they take a substance.
I don't know about you, but in my clinical practice, I get more problems with people stuck on benzodiazepines than I do with opioids or alcohol. I don't know what power do benzodiazepines have on people, that is the one drug that they feel that they cannot do without in the face of all of their suffering. You know, and then what do you think? What's your experience of that?
It's certainly a very long, slow process to wean patients off. And some are highly resistant to that. Resistance sounds like a bit of a pejorative sort of word, so I'll try and minimise the force of that in the sense that I'm not trying to blame them. It is very difficult for them to move away from their benzodiazepines, I think is how I'd express it. And sometimes they move down only half a milligram at a time and over 2 or 3 or 4 weeks, and then they hold there for a while and then they nudge down a little further. But the only thing I find useful is, so long as they're not pushing their doses up, giving them a little bit more control and letting them drive a bit, and then just using motivational interviewing and to some extent sort of an acceptance and commitment type framework to see them move towards that point where they no longer need them.
Can you explain that a little bit more? What do you mean by acceptance and commitment therapy in the context of benzodiazepine weaning, say for instance for an anxiety disorder?
Well, one of the things about acceptance and commitment therapy, it uses as a sort of starting off point with the patient creative helplessness. What's meant there is examining with the patient all of the things that they've been doing, how they've been trying to overcome this problem that they've had by, it might be taking benzodiazepines, it might be putting affirmations around their mirror in the bathroom, it could be all sorts of things, but all the same they're putting a lot of resources and energy into getting pretty much nowhere. And so we look at that and get them to recognise that despite all of these things, it's just not any better. Would they like to try something different? And then would they be prepared to make that commitment to confront these uncomfortable thoughts and feelings? And of course, with that, then the benzodiazepines can come into the picture. Well, you know, we're using that to numb these feelings, these anxious thoughts, and perhaps if we didn't take that, we would be able to deal with them more directly.
And I suppose that's one of the reasons why benzodiazepines have such power over people, because they do numb our pain. They give us an immediate sticking plaster, but they don't create healing. They're not like a proper bandage. You know, when you apply a bandage to a wound, yes, you stabilize the wound, it doesn't hurt as much, and then if you leave it for long enough, then the wound underneath heals. But with benzodiazepines, the wound underneath the plaster does not heal, does it?
No.
No. So is that one of the reasons why you think that people are just wedded to their benzodiazepines? And if so, how can we help people realize that that's not the case?
Sometimes it remains very fraught. I think I have to concede that it is, as you say, it's very difficult once somebody's started on benzodiazepines to persuade them that it's not the medicine for them. Occasionally it's kind of accidental. A patient who was seeing me couldn't get her medicines for one reason or other, didn't want to go and see another doctor, ran out, had a few days without, and discovered that life was pretty good. I'm not recommending that as a course of treatment, by the way, but sometimes it's just sheer serendipity that lets people see that. Sometimes it's sharing a little bit of education. One of the things I always come from is the coaching approach rather than the battling it out kind of approach with the patient.
Can you give us a little bit more on that then? What is the coaching approach?
Well, it's fairly standard, I think, that unfortunately, that therapists, practitioners and so on they know that what the patient's doing is bad for their health, so they just tell them. I find it more useful to find out what it is the patient needs, what do they hope that they might gain from any kind of therapy, and then come round to their side to be a coach to them. And so they might say, well, doctor, I really need these medicines, so I have to have them to be able to cope. Okay, I understand that's pretty important to you, to be able to get your medicines to be able to cope, but could I just share a little fact or two with you about the effect of these medicines and their eventual effects on your ability to be able to cope? And then when we start to talk about that, we get their permission to share that and talk about the fact that if you're taking these medicines, then it may well be that you're not able to engage in the thought processes that will allow you to actually completely extinguish the worries that beset you.
And I suppose, we're talking about need, and this goes back to the main theme of our talk. Why do patients feel they need to take benzodiazepines? What need is being satisfied or being met by the benzodiazepines? And if I was to think about the construct, I would be thinking about, rest. I think benzodiazepines provide a useful escape from pain, and they allow people to rest psychologically, but it's not a proper rest. There's no restoration. It's merely, I suppose, the absence of pain, but it comes with a cost. What would you say to that?
Well, I can think of other examples of these kinds of medicines and needs that people think that they achieve. It's not uncommon for me to hear from patients that they have to take them to keep their blood pressure under control.
Yeah.
They've been told that they're so worried they have to take at least an 8 of alprazolam every time they get worried, and that's not an exaggeration. And just to keep their blood pressure down. So it's sort of one of protection. I think, by the way, that's quite outrageous treatment, and that previous GP had retired, and apparently all of the notes had mysteriously disappeared.
Right. So yes, for some it may represent protection. For others, it may represent rest. For others, I suppose it may also represent creativity, because it allows them, or at least patients feel that they can be facilitated to work, to be creative, to write, to engage, and that's another need in itself, isn't it? But all of these needs might be met in the short term, but in the long term, benzodiazepines, I think, they come with a price that ultimately erodes their value. What do you think about that?
Well, certainly things like falls in the elderly, loss of motor control and so on. As I understand it, when you lose that control, certain individuals certainly struggle with actually even realizing that they've lost the capacity to control their limbs, those kinds of things. So there's a number of poor consequences, but certainly even at fairly modest doses, helping patients with other psychosocial interventions is really hindered by things like benzodiazepines, and gabapentinoids, I think, can also have an effect. Yeah,
I would agree with that. Now, this patient also has issues with his relationship with his parents and his relationship with his de facto partner, who seems to be abusing him financially and also physically and emotionally. It's not an uncommon scenario that we see patients who are substance dependent, who are actually the victims of trauma and abuse.
Well, that's right. I suppose the idea of mother's little helper, a woman, for example, has been subjected to abuse, domestic abuse, who just simply takes pharmaceuticals so that she might forget and not feel the pain. And perhaps in this man's case, he may well feel he's got no functional place to turn to. He might well be alienated from his family. Some families can be a bit like that, with people who are not in sort of standardised heterosexual relationships.
Mm-hmm. Yeah. And I suppose the other issue is, domestic violence. I mean, we all assume that domestic violence is perpetrated by a man on a woman, but we have to acknowledge that domestic violence comes in all shapes and sizes, and certainly in same-sex relationships, people are not immune to these issues. And to what extent is it the right thing to say, oh, you must leave your partner? I mean, I've heard that that's perhaps sometimes the wrong advice.
Yes. Well, that may be, they may have other attachments that they would be leaving behind. This man has his horses. Will he be losing contact with his beloved animals? There may be other important assets, maybe those things which have no particular monetary value but are deeply significant to him that are inside that household. There could be all sorts of things, all sorts of other concerns and worries that this man might have if he decides to leave.
Yeah. So once again, we have an example of a case where it's just so complex and there's no one size fits all, and there are so many threads to weave into the story of the patient's suffering and also potentially the solution. And if we're looking at solutions, how would you summarize the potential solutions for this patient?
Well, the solutions really lie within the patient. I don't feel that it's ever my role to tell a patient how to solve their life problems. I've not had the opportunity of speaking to this man, so if I was to talk to him, perhaps he would tell me that he has a vision of a better life for himself, whether that's without his partner or with his partner, but he might have a vision for himself of his better life, and then we would discuss what will that life look like, and what's happening now that seems to be headed in that direction, and what small changes might be made to get you to the point where you actually get to have that life that you dream of. My approach here is really, it's about having a conversation with the patient, and what's important to that patient, I don't actually know. I mean, is what's important to that patient that they don't take substances, or is there something else in their life? Do they want to get back into modelling? Do they want to start something new? Do they, I don't know, want to start an art gallery? Who knows? That might be their dream. We haven't asked them.
Yeah, that's a very interesting point. To what extent do you have dreams? To what extent are your substances enabling your dreams, or to what extent are your substances withholding you from achieving your dreams? Because you talk about, the coaching element. I'm very much aware when I'm treating this patient that his use of benzodiazepines is wrong, it's bad, it's inappropriate, it's bad prescribing, and he has to get off it. But he's telling me that his use of benzodiazepines is keeping him on an even keel. So, when I reflect back on my interactions with him so far, I have not yet asked him, what does he want in life? Where do his dreams take him? Because I haven't had that conversation. I'm therefore not able to tell him that his current medication regime is actually impeding him reaching those dreams.
Well, he may work that out himself.
Yeah?
Yeah. let's imagine for a minute, completely to fictionalise this man's existence from henceforth. Let's say he does want to start an art gallery, and you say, well, what's it going to look like, and what's your first clue that your life has changed? You know, that the miracle has happened. And he will say, well, I want to paint some of those pictures myself, and how will that happen? And, well, I'm going to go out and I'm going to get some canvases, and I love acrylics, I'm going to do rich colours in acrylics. He might get quite excited about that, and then he might come back to you later and say, all of these drugs are blunting my ability to express myself. I want to get off them. All right then, let's see what I can do to help you.
Yeah. So I suppose one way of looking at it is to unlock the desire in the patient to meet their own needs, their creative needs, and to link in medication safety with those desires. But, you know, a lot of my colleagues will ask me, well, what do we do in the meantime? You know, how do we manage their safety in the meantime? What do you say to that?
Well, I think in terms of giving advice, one of the most important elements, I feel, is seeking the patient's permission to share that little bit of advice. You know, look, it looks like you'll be on this for a little while. I'd like to just share with you what I would consider to be safe guidelines for use of these substances. And most people will give permission and take your advice. Like all humans, if somebody directly advises me, I'm not very good at listening. But I think, you know, but I think that is the case. You know, it offends against that human need for. That's probably where the wisdom part comes in. That every human needs to feel that he or she is the author of their own life story, and that they have a degree of wisdom. This man is the expert in his existence. He's the expert in his life. And so being humble enough to accept that he does know that, at the same time, as a friendly practitioner, just mentioning a few things that would make one worried, and then just setting down those clear safety boundaries, but without being confrontational. That's part of that coaching approach, I think.
Yeah. Andrew, I think we've run out of time far too quickly, but I really appreciate your take on this very difficult case, and thank you for your pearls of wisdom as usual. And I really do hope we can speak again very soon. Thank you.
Thank you.
That's all for today's show. My name's Dr. Fergal Armstrong. We'll see you next time.